Good evening, everyone. I think we should start now. About 5 in the room already. So just go ahead with the Greenberg session. If anyone has any questions, just stop me along the line. Questions, contributions, we can just do that as we proceed. All right, so we'll just start right away. So we'll start on spine films. Cervical spine must be cleared radiographically from the craniocervical junction, including the C7-T1 junction. Spinal injury precautions, using cervical collars, sandbags, inline cervical stabilization should be continued until the C-spine is cleared. Steps in obtaining adequate films are outlined in the spine injury section of the book. However, it's important to note that there are views for collection of spine films, C-spine films, and that's usually the press shoulder view or the swimmer's view. These views help to elaborate clearly the C7-T1 junction for adequate imaging of the cervical spine. Thoracic and lumbosacral spine films should be obtained based on findings and a mechanism of injury. They are rare for isolated tibia, especially in a patient who can tell you if they have spine tenderness on palpation. However, in patients where you notice minimal movement in the lower limbs or absent movements in the lower limbs, or presence of obvious deformity in the spine or bruising along the spine, it would be wise to gibbous, knuckles, and all that. It would be wise to actually do imaging of the spine or whatever level of the spine is found. The upper limbs are moving, but the lower limbs are not moving. Obviously, a thoracic film will be indicated. All right, so skull X-rays. Level 2 evidence reveals that skull X-rays are not recommended for evaluating mild traumatic brain injury. A skull fracture increases the probability of a surgical intracranial injury. In a comatose patient, it's a 10-fold increase. In a conscious patient, it is a 20-fold increase in a comatose patient, while a 400-fold increase in a conscious patient. However, significant intracranial injury found to have intracranial injury can occur with a normal skull X-ray. And skull X-ray was normal in 75% of minor head injury patients found to have intracranial lesions on CT, attesting to the insensitivity of skull X-rays. Skull X-rays affect management of only 0.4 to 2% of patients in most reports. So a skull X-ray may be helpful in two situations. If a CT scan cannot be obtained, the skull X-ray may identify significant findings such as a pineal, shifts in the cephalus, air fluid levels in the air sinuses, skull fracture, can be depressed or linear. However, sensitivity for detecting intracranial injury is very low for skull X-ray. And then if the patient has penetrating injury, the skull X-ray can localize radioactive objects. MRI scan in trauma. It's usually not appropriate for acute head injuries, and it is due to longer acquisition time, less access to the parents during the study, increased difficulty in supporting patients, and because it requires special non-magnetic ventilators, one cannot use most intravenous pumps, and MRI is less sensitive than CT for detecting acute blood. And there were no surgical lesions demonstrated on MRI that were not evident on CT in one study. There may be some additional benefits in combining CT with an MRI performed directly in the emergency department. MRI may be helpful later after the patient is stabilized to evaluate brainstem injuries, small white matter changes, punctate hemorrhages in the corpus callosum seen in diffuse axonal injury. Spinal MRI is indicated in patients with spinal cord injury. Rapid sequence MRI may be useful for follow-up in pediatrics to minimize radiation exposure. So essentially, what they're just trying to say here is that the usefulness of MRI scans on trauma is very limited. Majorly, Particularly, it's important in spine injuries, of course, because majority of C-spine injuries, especially subaxial spine injury, requires you to do a CT scan, an MRI of the spine in order to be able to localize the level of the, if there's a posterior ligamentous complex injury, to show you. If there's cord contusion, to show you. There's disc prolapse compressing of the body, to show you. Narrowing of the canal, to describe it. You'll be able to see clearly all that. Even if there is listhesis, you'll be able to see it. What a CT of the C-spine will show you, it's most likely if there's a bony fracture or a listhesis, extent of listhesis, and then if there is facets injury and all that. So those things you see on CT, but MRI is very, very, very helpful for spine trauma. While for brain injury, MRI is not too helpful because, of course, MRI will not show you the skull. It doesn't really show the skull clearly. That's one. So poor bone interrogation. Two, it has long acquisition time. So, and your patient is unstable. So you delay, there's a lot of delay. And if the patient is restless, you have very poor films because the patient needs to be sedated. That's another thing. And it will also impair, sedation will impair your assessment subsequently. So that's another one. That's two. Three, because if the patient is unstable and needs ventilation and all that, you need to use MRI compatible equipment. So for infusion, for ventilation and all that. So all those things really are not really very helpful. So MRI is not very supportive. Then the other thing is that MRI is not very sensitive for different acute bleeds compared to CT. And it was noticed that majority surgically important lesions that can be seen on MRI can also be seen on CT scan. So doesn't have any comparative advantage preferably to CT, except of course in patients with mild head injury or diffuse axonal injury, two spectrums. In mild head injury, MRI will show you clearly. In MRI injury, mild head injuries with some deficits, MRI may show you plenty of subtle bleeds that are not seen clearly on CT scan. For DAI, MRI will show you a lot more bleeds at the level of the gray-white matter interface. It will show you bleeds in the corpus callosum or in the brainstem. So it will help you clearly classify the severity of the DAI, the patient, from 1 to 2. So that's some of the advantages of MRI compared to CT in trauma. Essentially, that's it. So next is arteriogram in trauma. Cerebral arteriogram is useful with non-mesial penetrating trauma. Indications for admission to the hospital. Okay. So non-mesial penetrating trauma on arteriogram can be helpful, especially when you're worried about the possibility of development of traumatic aneurysms or when you notice the bleed that is very close to intracranial vessels or arteries, like maybe in the region of the skull base or around possible regions of supply of major arteries in the brain. So one may want to do arteriograms to be sure of whether the vessels are currently bleeding and all that. So ER management of minor or moderate head injury. The indications for admissions to the hospital versus observation at home. Patients who may be discharged with observation at home. Patients with mild TBI, GCS of 14 to 15 who meet criteria, who meet certain criteria can be managed with observation at home with written head injury discharge instructions, which we in my center usually call the head injury advice. For those not meeting discharge criteria, there are also admission orders that can be given. So, criteria for observation at home. If the head CT scan if patient does not have an indication for a head CT, if the initial GCS is greater than or equal to 40, the patient is now neurologically intact. Amnesia, that's if the level of amnesia for the event is acceptable. There's a responsible sober adult that can observe the patient at home. Patient has reasonable access to return to the hospital emergency room if needed. And there's no complicating circumstance, there's no suspicion of abuse or domestic violence. And the patient can be discharged home. Then also there are sample discharge instructions. This is the head injury advice here. Here it says that seek medical attention for any of the following. There's a change in level of consciousness, including there's a decline, more like a decline, not increase, of course. If you increase, you're happy. So there's a decline in level of consciousness, including difficulty in awakening, abnormal behavior in patients, as irrational behavior, irrational talk, patient becoming excessively aggressive, or is becoming less responsive, then we need to bring the patient back to the hospital. There's worsening of headache, slurred speech suddenly becomes slurred or no longer becomes aphasic, weakness or loss of feeling in an arm or leg, persistent vomiting, has at least 2 or more episodes of vomiting, enlargement of one or both pupils, and that does not get smaller when bright light is shined on it, seizures, significant increase in swelling at the injury site. All this require patient to be returned back to the hospital. So usually it's advised that the patient should not take, in some countries, medications or sedatives stronger than PCM for 48 hours. And it's advised that the patient should not take aspirin because of the risk of bleeding. Admitting others for minor head injury. So patients should be admitted, given bed rest with elevated of the bed to 45 degrees, 2-hourly assessments, and hourly if it is patient is in ICU. Contact physician for neurologic deterioration. Neopa oral until patient is alert, then clear fluids, advanced as tolerated. Isotonic IV fluids, normal saline plus 20 milliequivalent of potassium chloride to run at maintenance. 100 cc for an average size adult per hour, 100 cc per hour. Then pediatrics, 2006 CMQ, right, per day. The concept of turning the patient dry is obsolete. Running the patient dry is obsolete. Yeah, so the patient should be adequately, should have adequate fluid administration, at least maintenance level. Mild analgesics, using acetaminophen, codeine, or tramadol if necessary. Then antiemetic should only be given if patient is vomiting and if you have addressed the cause of vomiting. Because if the patient is persistently vomiting and all that, one should rule out features of raised intracranial pressure and any other attendant issues that may be causing vomiting patient before you go ahead and give antiemetics. For moderate head injury, others are for similar orders as for mild head injury, except that patient is kept neopa oral if there is going to be surgical intervention, including placement of an ICP monitor. For patients with GCS of 9 to 12, these ones are saying admit 9 to 12 to ICU, but this is not the standard of care in my setting. Usually admit them straight to ward or HDU if there is, but we don't have an HDU, but that would have been the best place to manage this ones. For GCS of 13, because only admit to ICU if there's abnormal CT, hemorrhagic contusions, and all that. When patients with normal or near normal CT scans should improve within hours, and any patient who fails to reach GCS of 14 to 15 within 12 hours should have a repeat CT scan done. Patient with associated severe systemic injuries. Patient has an intra-abdominal injury. Well, a fast scan is what is standard of care now. Nobody does DPL anymore. To assess for intra-abdominal hemorrhage. Negative and patient is amicably stable. Patient should have a cranial CT plus or minus actually abdominal CT. Patient with grossly positive DPL or fast may need to be rushed to the OR for emergency laparotomy. Yeah, without it's difficult in this patient that must be realized. So guidelines are offered. So Caution, many patients with severe trauma may be in DIC. Yeah, and because the brain is such rich in trauma past, operating patients in DIC is really disastrous. So at least one should do PTI now, APTT. If patient's GCS is greater than 8, which implies that this patient is recognizing, operative neurosurgical intervention is probably not required. Utilize good neural anesthetic techniques, elevate the bed of the head, judicial admission of IV fluids, avoid the prophylactic ventilation, obtain a RTT candidate post-op. Patient has focal neurologic deficit and exploratory borehole replaced in the OR simultaneously with treatment of other MD. Patient is guided by the pre-op deficits. If there is severe head injury, issues of less than or equal to 8 without localizing sign, or if initial borehole is negative, there is no preoperative neuro exam, then measure the ICP inside the ventriculostomy catheter. The lateral ventricle cannot be entered after 3 passes. It may be completely compressed or it may be displaced. And an intraparenchymal fiber optic monitor or subarachnoid port should be used. Normal ICP unlikely. It's unlikely that a surgical lesion exists if the patient's ICP is normal. Manage ICP medically, and if an IV intravenous intraventricular catheter was inserted with CSF drainage. If the patient has elevated ICP greater than equal to 2 millimeters of mercury, inject 3 to 4 cc's of air into ventricles, then obtain portable intraoperative AP skull X-ray, intraoperative pneumoencephalogram to determine if there's any midline shift. If there's mass effect, with greater than or equal to 5 millimeter measure, explore surgically with boreholes on the side opposite the direction of the shift. If no mass effect, intracranial hypertension is managed medically and with CSF drainage. Routine use of exploratory bore for children with GCS approximately GCS of 3 has been found not to be justified. Okay, so these are some cautions, like patients who you have associated injuries, you've not done a CT scan, all this information. So patients who have not had the benefit of having a CT scan, and then you need to do a trauma laparotomy or a damage control surgery for. So while you're intra-op with the damage control surgery, while the general surgeons are doing their thing, the trauma neurosurgeon can actually do a few things to assist. So these are the things you can do. If the patients, they say if the GCS is greater than 8, you just leave the patient alone. Not the patient 30-degree end up and ensure you give IV fluids and all that. However, the patient has a neurologic deficit. You can do an exploratory bowel opposite the site where the deficit is to assess if your borehole, if the this thing, and then of course opposite the site of the deficit and localize the deficit to the system. So of course, whether it is frontal, parietal, or occipital, visual, sensory, auditory, and all that, likely the areas where all these symptoms can be. And if it is motor symptoms, of course, where it likely can be located. So these are some of the things. So one will do an exploratory bore for that situation. Then if patient has a severe head injury, there is no localizing symptoms, and there is no pre-op neuro exam. The patient was just rushed from the Medivac down directly to the theater. So these are some of the things that can be done for the patient. So it's best to place an ICP both monitoring or something to measure the ICP plus or minus therapeutics. So therapeutics here will be that you do a ventriculostomy. In situations where the ventricles are slit ventricles and you cannot cannulate ventricles, they have attempted 3 passes and we couldn't access the ventricle. And one can go ahead and place a parenchymal bolt, or a subarachnoid bolt, parenchymal fiber optic monitor or a subarachnoid bolt can be placed. So when you place that and then you now measure the ICP, and if the ICP is raised, then one can manage ICP medically. If the ICP is elevated and you were successful in doing your ventriculostomy, you can still go ahead and now do an intraoperative pneumoencephalogram. So you can use your C-arm to assess if there's midline shift. There's midline shift, and is greater than 5 millimeters to the opposite side, and you do you drain. If it is to the opposite side, you do an exploratory borehole on the ipsilateral side. If it is to your side, to the ipsilateral side, you do a contralateral exploratory borehole to see if you can actually find whatever is causing the midline shift and compress the patient. Essentially that, and then the last thing is that electric balls have not been advantageous in children who GCS is 3. All right, so the next is fat embolism syndrome. We said it's most often seen after a long bone fracture, but may include clavicular, tibial, and even isolated skull fracture. Although almost all patients have pulmonary fat embolism at all percent. The syndrome is usually mild or subclinical. Only 10 to 20% of cases are severe. The fulminant form leading to multi-organ failure is rare. Liver findings usually appear within the first 12 to 72 hours of injury and do not always include complete classic triad. Because the triad is that of acute respiratory failure, hypoxemia, followed by neurologic dysfunction and petechial rash. Yep. So other possible findings include pyrexia and retinal fat embolism. There's no specific test for fat embolism syndrome. The following have been proposed, but poor sensitivity and specificity. Presence of fat globules in the urine, which is only positive in 1/3 of patients. Serum globules, in fact, globules in urine and serum can be indicative, and for urine is only positive in 1/3 of patients. Serum lipase activity can also be assessed. In case of unexplained neurologic or pulmonary abnormalities, it will be possible to diagnose fat embolism syndrome if on bone alveoli about greater than 5% of cells in washing stain for neural fats with red oil. Non-specific tests include ABG findings of hypoxemia, respiratory alkalosis, hypoxemia, hypocarbia from hyperventilation and respiratory alkalosis. Treatment of patients with fat embolism syndrome is pulmonary support with oxygen, mechanical ventilation if necessary, including use of PEEP, positive expiratory end pressure, and the use of steroid is controversial in this patient. Ethyl alcohol can be given to decrease serum lipase activity, and heparin. Both have not been shown to have any benefit. So use of steroids is controversial. Ethyl alcohol and heparin not beneficial. Early operative fixation of long bone fractures may reduce the incidence of fat embolism syndrome. Outcome usually related more to the underlying injuries. Although fat embolism syndrome is usually compatible with good recovery, 10% mortality is usually quoted. All right, so the next complication here is indirect optic nerve injury. Okay, so indirect optic nerve injury. So approximately 5% of head injured patients manifest an associated injury to some portion of the visual system. And approximately 0.5 to 1.5% of head trauma patients sustain indirect injury to the optic nerve as opposed to penetrating. Most often, this usually occurs from an ipsilateral blow to the head, usually frontal, occasionally temporal, rarely occipital. The optic nerve may be divided into 4 segments, which is the intraocular part, 1 millimeter in length, intraorbital, so 25 to 30 millimeters, intracanalicula, 10 millimeters, and intracranial, 10 millimeters. Actually, some people have actually called that intraorbital part the intraconal portion because it's usually located within the cone of muscles. So they have the intraorbital, intraconal, or intraorbital, and then you have the intracanalicular, which is located within the optic canal, and then you have the intracranial components. both the intracanalicula and the intracranial are about 10 millimeters in length each, while the intraconal or intraorbital is 25 to 10 millimeters, while the intraocular component is just 1 millimeter. Thank you. The intracanalicular segment is the most common one damaged with closed injury. Fundoscopic abnormalities visible on intra exam indicates anterior injuries to the intraocular segment, optic disc, or the 10 to 15 millimeters of intraorbital segment immediately behind the globe, where the central retinal artery is contained within the optic nerve, whereas posterior injuries occurring posterior to this but anterior to the chiasm take 4 to 8 weeks to show sign of disc pallor and loss of the retinal nerve fiber layer. So the more anterior the injury, the earlier the fundoscopic abnormalities. That's the optic, usually of course, optic atrophy can be noticed, the earlier it will be noted. So is for posterior injuries, that's the ones in intracanalicular and intracranial. They usually show signs of disc pallor. That's early signs of optic atrophy, about 4 to 8 weeks later. So treatment, there's no prospective study has been carried out to identify or determine optic nerve injury, indirect optic nerve injury. However, optic nerve decompression has been advocated for indirect optic nerve injury. The results are not clearly better than expected management. The expression that documented delayed visual loss appears to be a strong indication for surgery. Transensmoidal is the accepted route and is usually done within 1 to 3 weeks from the trauma. The use of mega-dose steroids may be appropriate as an adjunct to diagnosis and treatment. Interestingly, we just operated a case of indirect optic therapy injury. I don't know whether to call that indirect or direct now, because the patient actually had trauma. It wasn't penetrating, but there was transmission and fracture that narrowed the optic canal. And that intraoperatively, we were able to did a frontal temporal craniotomy, and then able to retract the frontal lobe, identified the optic canal, and we decompressed it. There was a lot of hematoma around it. We decompressed the optic nerve in that location. I'm hoping, since it's correctly in ICU, I'm hoping there will be some good outcome from that. All right, so next is post-traumatic hypopituitarism. I don't know if we have any contributions or comments to make right now before we proceed. Comments, contributions. Okay, so in absence of any, we'll proceed to post-traumatic hypopituitarism. So although trauma is a rare cause of hypopituitarism, it may follow closed-head injury with or without basilar skull fracture or penetrating trauma. In approximately 20%, there's 20 cases have been said in literature, all had deficient growth hormone and gonadotropins. 95% had corticotropin deficiency, 85% had reduced TSH, 63% had elevated prolactin, and only 40% had transient or permanent TI. So we can see that it is still the go for, okay, this time there's no corticotropin now. It's still prolactin that is the last shot, but it's not the classical go for the adenoma. Here. It's not true. So you now go adenoma for please. So there's an exchange between corticotropin as TSH and this thing, corticotropin. That's okay, ACTH. Sorry, that's what I was trying to remember. There's a swap between ACTH and TSH. All right, so and then transient, for only 40% had transient or permanent diabetes insipidus. So essentially that's at 95, 85, 63, 40. 30%. The other converse in this case, or similar situation also happens in obstetrics. You have Sheehan syndrome, hypopituitarism from stress ischemia following postpartum hemorrhage. Explanatory boreholes. In a trauma patient, the clinical triad of altered mental status, unilateral pupillary dilatation with loss of light reflex and contralateral hemiparesis is most often due to upper brainstem compression by uncal herniation, uncal transtiturial herniation, which in majority of trauma cases is due to an extraaxial intracranial hematoma. So we have a triad, right, of altered mental status, that's one, unilateral pupillary dilatation with loss of reflex, and contralateral hemiparesis, which is usually due to an upper brainstem compression by uncal transtiturial herniation. Now, furthermore, the prognosis of patients with traumatic herniation is poor. Outcome may possibly be improved slightly by increasing the rapidity with which the compression is undertaken. However, an upper limit of salvageability is probably still only approximately 20% satisfactory outcome. Okay. Boreholes are primarily a diagnostic tool as bleeding cannot be controlled and most acute hematomas are too congealed to be removed through a borehole. However, if the borehole is positive, it's possible that the modest decompression may be performed and then definitive clinician can be undertaken incorporating the borehole. With widespread availability of quickly accessible CT scanning, exploratory boreholes are infrequently indicated. So, yeah, obviously, I don't think in my practice, since I've started neurosurgery, I've ever had to do any exploratory borehole. But I'm sure in trauma centers, like in standard trauma centers, I know there might be certain needs to do that, especially when the patient is significantly down and you may have to do a damage control surgery and all those things we discussed earlier. But ordinarily, for an isolated head injury case, one may not necessarily need to go ahead and do that. And then in certain parts of the world now, like places like Denmark and the Netherlands, I think, immediately a trauma case comes to the trauma unit, it just goes, it has a total body CT. So it just, like, it's the door. As you're passing in, the trolley just wheels you to a CT scanner as you're entering to the trauma bay. So essentially, the patient just gets a diagnostic CT scan, whole body CT, whole body CT essentially, low dose whole body CT scan, just gets a swipe. So in that situation, those kind of people will never be talking about exploratory boreholes anymore. And of course, I think in presence of availability of CT scan, exploratory boreholes really indicated. But then something that surgical residents needs to know what it is. Something that has been in the practice at some point. So yeah. Indications, clinical criteria is based on deteriorating neurologic exam findings. Clinical criteria based on deteriorating neurologic examination. Indications in the ER are a patient dying of rapid transtiturial herniation or brainstem compression that does not improve or stabilize with monitor and hyperventilation. Indicators for transtiturial herniation, compression study drop in GCS, unilateral pupillary dilatation, and non-responsive pupillary dilatation, paralysis or deceleration develops, usually contralateral to the blood pupil. As recommended, situations where criteria should be applied. Neurologically stable patient undergoes witness deterioration as described above. A weak patient undergoes same process in transport, and changes are well documented by competent medical or paramedical personnel. Other criteria, some patients needing emergent surgery for systemic injuries, positive peritoneal lavage, hemodynamic instability, where there is no time for a brain CT. So this other criteria too was what we described earlier. First criteria is this: imminent or ongoing transtiturial herniation. A patient who was initially noted to be fully conscious or awake or neurologically stable, or was awake, you then notice to be rapidly deteriorating with features of transarterial emotion. This triad of sudden drop in GCS, pupils fixed and dilated on one side and on the contralateral side, progressive limb weakness. So the management is controversial, and the following should only serve as guidelines. So patient fits the above criteria: emergent operation for systemic injuries with failure to improve in monitor and hyperventilation. CT scan cannot be performed and interpreted immediately. The treatment should not wait for CT scan. In general, if the OR can be immediately available, balls are probably done there, equipped to handle craniotomy, better lighting and sterility, dedicated scrub nurse, especially in older patients greater than 30 years, not involved in motor vehicle accidents. This may be more rapidly diagnosed and treat extraaxial hematomas in inflammatory patients, although no difference in outcome has been proven. If there's a delay in getting to the OR is foreseen, emergency boreholes in the ER should be performed. Placement of boreholes as outlined below. Yeah, so position, shoulder roll, head turned with side to be explored up. 3-pin skull fixation and used if concerned about possible aneurysm or AVM to allow for retractors and increased stability. If additional stability is desired, otherwise a horseshoe head holder suffices and saves time and makes it easier to turn the head to access the other side if needed. Choice of side of initial for initial ball. Start with the temporal ball hole on the side. One, it's lateral to a blown pupil. This will be on the correct side in approximately greater than 85% of epidurals, and the other extraaxial mass lesions. If both pupils are dilated, use the side of first dilating pupil, if known. If pupils are equal or it is not known which side dilated first, place on the side of obvious external trauma. If no localizing clues, place ball on the left side to evaluate and decompress the dominant hemisphere. So, 4 steps. Start with the side ipsilateral to the blown pupil. If both pupils are dilated, start with the side of the one that initially started dilating. If you're not sure if both are equal, and you're not sure which one started dilating first, if they are dilated, then place on the sites where you can see obvious sign of external trauma. If there's no localizing clue, then just go ahead and start with left side. Those are the steps. Approach. Balls are placed along a path that can be connected to form a trauma flap. The craniotomy becomes necessary. The trauma flap is so-called because it provides wide access to most of the cerebral complexity, permitting complete evacuation of acute blood clots and control of most bleeding. First, outline the trauma flap with a skin marker and start at the zygomatic arch. 1 cm anterior to the tragus, spares the branch of the facial nerve to the frontalis muscle and also spares the anterior branch of the superficial temporal artery. Then proceed superiorly and cuff posteriorly at the level of the top of the pinna. 4 to 6 cm behind the pinna is taken superiorly. When you get 4 to 6 cm behind the pinna, you take it superiorly up to 1 to 2 cm ipsilateral to the midline, and cover anteriorly and end behind the airline. So obviously, this is the trauma flap. This is the image showing the trauma flap. And then we'll see the borehole locations. First borehole is the temporal borehole. Should be placed over the middle cranial fossa on the side of the dilated pupil. There is one just superior to the zygomatic arch. Provide access to the middle fossa, most common site for epidural hematoma. Usually allows access to most convectivity subdural hematoma, as well as proximity to middle meningeal artery, region of terror. If no epidural hematoma the dura is open, if it has bridge discoloration, suggests subdural hematoma. There is a strong suspicion of a mass lesion on that side. If negative, usually perform temporal borehole and contralateral side in the same location. If negative, and if a CT cannot now be done, and the OR immediately available from there, proceed to ipsilateral frontal borehole. So this is 1. This is where you place it. 1 is where you place your temporal. 2 is where you place ipsilateral frontal. 3 is where you place parietal, and then 4 is where you put the prefrontal borehole. So that's how we explore start from temporal, go to frontal, go to parietal, go to prefrontal, 1, 2, 3, 4, along the trauma flap for temporal down, up frontal, posterior, parietal, then of course you have to go posteriorly to do your prefrontal. So essentially that's exploratory borehole. Yeah, it says that here that in 100 trauma patients undergoing transitory reanimation of brainstem compression, as outlined above, exploratory boreholes exploratory boreholes, bilateral, temporal, frontal, and parietal done in the OR were positive in 56%, lower rates in younger patients less than 30 years, and those in vehicular accident as opposed to falls or assaults. Subdural was the most common extraaxial mass lesion alone, and with lateral in 70%, bilateral in 11%, and combination with epidural or intracranial hemorrhage in greater than 9%. Okay. When boreholes were positive, the first borehole was on the correct side in 86% of time when placed as suggested above. 6 patients had significant extraaxial hematomas mixed with exploratory boreholes, mostly due to incomplete borehole exploration. Only 3 patients had the above neurologic findings as a result of intraparenchymal hematomas. So outcome, mean follow-up, 11 months, range of 1 to 37%, 1 to 37 months. 70 to 100% died. No morbidity or mortality was directly attributed to the boreholes. 4 patients, good outcome. 4 with moderate disability had positive boreholes. All right. 70 of 100 of the 100% in this study died. No morbidity or mortality was directly attributable. So obviously, for you to decide to do an exploratory borehole, the patient must be really, really bad. Imminent transtentorial fibrillation. Even though it may be positive signs, some of the patients eventually die because of the severity of the injury. All right, so sorry, references. Just give me a minute. The next discussion is on concussion, high altitude cerebral edema, and cerebrovascular injury. Concussion occurs in a subset of patients in mild TBI. It is considered mild because it's usually not life-threatening by itself. While most victims recover completely, effects of concussion can be serious and in some instances be lifelong. Much of the discussion in this chapter refers to concussion in sports, which is the largest source of data on the subject and generalized. Association to other types of trauma must be done circumspectly. There's a move away from concussion grading scales. The current recommendation is for the diagnosis to be determined by an experienced examiner with assistance of various assessment tools, ideally with availability of pre-injury baseline metrics in comparison. Concussion can occur without a direct blow to the head, e.g. with violent shaking of the torso and head. Concussion symptoms can present soon after an insult or in a delayed fashion, which the subject may not be aware they might have sustained a concussion. It's seen in 1.6 to 3.8 million. There are about 1.6 to 3.8 million concussions per year in the US from sports and recreational activities, and is estimated that 50% of concussions go unreported. There's no clear evidence to support a genetic predisposition to concussion. However, apolipoprotein E4, ApoEG219T promoter, and tau exon 6 have been studied in small retrospective and prospective trials without definitive association. Concussion, there's no universally accepted definition for it. Of the many contemporary definitions, most key elements are contained in the concussion in sports group consensus definition, which is summarized below. However, opinions differ into whether there's any long-term effect of concussion that it necessitates a different diagnosis. So concussion is a complex pathophysiological process affecting the brain, resulting in alteration of brain function that is induced by non-penetrating biomechanical forces without identifiable abnormalities in standard surgical imaging. So first things first, it's complex pathophysiological process affecting the brain, resulting in alteration in function that is induced by non-penetrating biomechanical forces without identifiable abnormality in standard structural imaging. Concussion in sports group elaborates on this definition as follows: results in a graded set of neurological symptoms that may or may not involve loss of consciousness. Symptom onset is usually rapid, short-lived, and resolves spontaneously. Manifestation may include transient defects in balance, coordination, memory, cognition, strength, or alertness. It may result in neuropathological changes, while the acute clinical symptoms largely reflect a functional disturbance rather than a structural injury. Resolution of the clinical and cognitive features typically follows a sequential course. That's for concussion. So these are just the criteria. I think it's good to just take some time to look at it. This might be MCQ hotspots. Concussion versus mild traumatic brain injury. Concussion and mild TBI are not interchangeable. Concussion may be thought as a subcategory of MTBI, on the less severe end of the brain injury spectrum, though with similar clinical symptoms. The major difference between the two is that mild traumatic brain injury may demonstrate abnormal structural imaging, such as cerebral hemorrhage, contusion, concussion, and concussion by definition must have normal imaging studies. Mild TBI is part of an injury severity spectrum, primarily based on the Glasgow Coma Scale score. TBI is evaluated 6 hours after injury and differentiated into mild, moderate, and severe. Concussion is evaluated directly after the insult and based on a clinical diagnosis aided by a multitude of standardized assessment tools to include concussion under the full spectrum of traumatic brain injury. Then it must fall at the low end of MTBI and overlap with the subset of minimal injury. Most mild TBIs with negative imaging can be considered concussions, but the majority of sports concussion cannot be classified as mild TBI. Okay, so the risk factors for concussion. History of previous concussion increases the risk of further concussion. Being involved in an accident like a bicyclist, pedestrian, or motor vehicular collision, a combat soldier, victim of abuse, falling, especially pediatrics or elderly. Males are diagnosed with sports-related concussion more than females, due to an increased number of male participation in sports studied, but females have a higher risk overall when compared to males who play in the same sports. Anticipating in sports with high risk of concussions like American football, Australian rugby, ice hockey, boxing. Soccer has the highest risk for females. For contrast, sports with the lowest risk of concussions: baseball, softball, volleyball, and gymnastics. Okay. Body mass index of greater than 27 kg per meter square. In less than 3 hours of training per week increases the risk of sport-related concussion. So when a patient is overweight to obese with less than 3 hours of training per week, there's a higher risk of concussion. Triggers, findings suggestive of concussions are listed. Okay, so I think, yeah, and the diagnosis should be considered when any of this. So these are the triggers here. I'm sorry, the findings. Physical findings: vacant stare or befuddled expression, dazed or stunned, headache or pressure sensation in the head, nausea, vomiting, or all this. So physical, cognitive, emotional, or sleep. Okay. In children, listlessness, easy fatigability, change in sleeping pattern, irritability, hearing dazed, balance impairment, excessive crying, change in eating habits, and loss of interest in favorite toys. So clinical evaluation for concussion. There is no physiologic measure that has been identified that can detect the underlying changes that lead to manifestations of concussion. Therefore, the diagnosis relies on self-reporting of abnormal function, symptoms observed, physiological abnormal signs, and including assessment of cognitive dysfunction. Sometimes with the assistance of imaging tests to rule out a structural substrate. A clinical diagnosis of concussion is made if there are abnormal findings of balance, coordination, memory, cognition, strength, reaction speed, or alertness after a traumatic insult to the head. Findings include confusion. I think these are all in the table. Patients themselves may be unaware whether or not they experienced loss of consciousness. Frequent neurologic neurobehavioral features of concussion are shown in the table. In children who may not be able to verbalize symptoms, they have also been seen. Positive imaging findings would necessitate a more severe diagnosis of cerebral contusion. So to take a concussion-specific symptom survey, so the patient will be inquired about headache, nausea and vomiting, light sensitivity, tinnitus, feeling like being in a fog, or sleep disturbances. History of diagnosis that might have an impact on the assessment or on a current concussion. History of prior concussions, headache history, ADHD, learning disabilities, medications. The patient has been on any medication might affect alertness or cognition. Perform a good general neurological exam, include a concussion-specific knowledge, check patient's orientation, to assess for amnesia and impaired verbal memory. Balance, Greenberg test to look for significant sway of braking stance, single leg stance, eye movement, autokinetic nystagmus, smooth pursuit. Simultaneous task performance, the snap fingers while walking. Include assessment aids like sideline tools as appropriate. Assessment aids, there's no single validated assessment tool to diagnose concussion. It's primarily a clinical diagnosis that is ideally made by a certified healthcare provider who are familiar with the patient. Based on a detailed history of examination and continual evaluation from the sideline to the clinic. The diagnosis is ideally made within 24 hours of injury. The assessment may be made by concussion assessment tools such as CAT3, impact. No test has shown high validity on independent testing, and no test should be used as sole method for diagnosing concussion or for determining suitability to return to play. Athletes also led to game some baseline tests to avoid removal from play after a possible concussion. SCAT3 is a sports concussion assessment tool, third edition, and it was derived from the 2012 Zurich conference. SCAT has become the most commonly used standardized tool for sideline assessment of sport concussion. Its sensitivity and specificity for concussion assessment tools change over the course of concussion. So a tool designed for sideline use is not appropriate for office use. SCAT3 is a trademark tool developed by a concussion in sports group for use only by medical professionals for assessing sports-related concussion. And this is where it can be found to be used in players of 13 years or older. Child SCAT3 is available for 12 and younger. It's a multimodal assessment tool with 8 sections that include self-reported symptoms and evaluation of functional domains such as cognition, memory, balance, gait, motor skills. It takes 8 to 10 minutes to administer, and normal SCAT3 does not rule out concussion. It has not been validated. Other types of sports concussion assessment tools may be viewed on YouTube. Many can be viewed on YouTube. Neurocognitive testing may be up to 20 minutes to administer. SAC, standardized assessment of concussion. Impact, PCSS, CSI, balance error scoring system, SOT, sensory organization test. Concussion quick check. King-Devick eye movement testing, which takes about 2 to 3 minutes administered on printed cards, a tablet computer. Well, so all this, one can do formal neuropsychological testing if the patient has prolonged cognitive symptoms. There's concussion biomarkers. Monomoiety has been identified that can reliably diagnose concussion on serum or saliva testing. Neuron-specific LONIs, S100 and cleaved tau protein have been studied for prognostication after mild TB and concussion. S100 has demonstrated only a 33% sensitivity for post-concussive symptoms and a 3% sensitivity for extended Glasgow outcome score, less than 5 at 1 month. And that study involving pediatric patients with mild TB showed no difference in levels of NSE or S100 in asymptomatic and symptomatic children. The prospective study found no significant correlation between cleaved tau protein and post-concussive syndrome in patients with mild TB. All right. Oof. Okay, so on-site sideline evaluation, and we just have 2 pages to go. Should be done. We started the session at 8:15 or thereabouts, so I think it's not over 4 minutes. Should be done in time for case-based. Any individual suspected of having a concussion should be removed from activity and assessed by a licensed healthcare provider trained in evaluation and management of concussion. Attention to excluding a cervical spine injury. If no provider is available, return to the activity is not permitted and urgent referral to a physician should be arranged. After ruling out emergency issue, the provider should perform a concussion assessment, may employ standardized tools or other methodologies. Patients should not be left alone. Serial evaluations for signs of deterioration should be made over the following few hours. For return to play guidelines, indications for imaging or other diagnostic testing in concussion. There's no imaging modality that is diagnostic for concussion. Imaging in concussion is typically used to rule out more serious traumatic injuries or sometimes to clear a patient of occult intracranial pathology before general anesthesia or other injuries. Typically, CT or sometimes MRI is utilized. CT scan in concussions. CT scan should not be performed routinely for mild TBI. Validated decisions should be employed to determine when imaging is indicated. Other studies, imaging and electrodiagnostic. DTI is used to quantify white matter tract integrity throughout the brain. 4 types of analysis method. Voxel analysis, regional interest analysis, histogram analysis, and tractography. There is no strong consensus regarding the best method for utilizing DTI for diagnosis or prognosis in individual patients. But multiple studies have shown group differences in DTI parameters between MTBI and control patients. Functional MRI is 2 types, task-based MRI and resting state MRI, and is based on the blood oxygen level dependent effects as bold, in which specialized MRI sequences measure and detect regions of increased oxygen-rich blood flow to areas of upregulated neuronal activity. Both task-based and resting state MRI modalities have shown group differences between mild TBI and control patients, specifically in frontal lobe dysfunction. But further studies need to be completed on both a single time point and longitudinal basis before these techniques can be widely adopted for individual diagnosis and therapeutic guidance. Imaging studies are currently used primarily in concussion research, like PET, SPECT CT, MRS, quantitative electroencephalogram digitized EEGs are analyzed for relative energy at different frequencies to assess brain activities, patterns of cortical activation, and neuronal networks. Post-concussion studies are compared to baseline. Thus far, there are no quantitative electroencephalogram features or other electroencephalogram findings for that matter that are specific and sensitive for concussed patients. All right. So after all this story, none of these studies are validated for assessment of concussion. Okay. Acute pathophysiology. Biomechanical force results in unregulated ionic flux, um, potassium, sodium, calcium influx, and unrestricted hyperacute glutamate release from sublineal mechanoporation of lipid membrane. So, of course, we have excitotoxicity occurring at the cellular level. This triggers voltage/ligand-gated ion channels, causing a cortical spreading depression-like state that is thought to be the substrate behind immediate post-concussive symptoms. Subsequently, ATP-dependent ionic pumps are excessively upregulated to restore cellular homeostasis, causing widespread intracellular energy reserve depletion and an increase in ADP. Cells then pass into a state of impaired metabolism, energy crisis that can last up to 7 to 10 days and may be associated with alteration in cerebral blood flow. This impaired metabolic state is associated with vulnerability to repeat injury as well as behavior and spatial learning impairments. Cells also undergo cytoskeletal damage, external dysfunction, and altered neurotransmission, with the as yet unproven impression that each of these pathologic processes correlate with a separate symptomatology. So, physiologic perturbations and their proposed corresponding symptomatology. Ionic influx associated with migraine headache, photophobia, and phonophobia. Energy crisis results in vulnerability to secondary injury. External injury, impaired cognition, slowed processing, slow reaction time. Impaired neurotransmission, impaired confusion, slow processing, slow reaction time. Protease activation and altered cytoskeletal proteins and cell deaths can result in chronic atrophy and persistent impairments. So the final thing, I guess, is post-concussion syndrome. It occurs in approximately 10 to 15% of concussed individuals. Most concussion-related pathologies, there are multiple definitions for post-concussion syndrome. An amalgam of some definitions is as follows. Patients having greater than 3 symptoms, including headache, fatigue, dizziness, irritability, difficulty concentrating, memory difficulty, insomnia, and intolerance to stress, emotional, alcohol, and symptoms, intolerance to stress, emotional, alcohol. The symptoms must begin within 4 weeks of injury and remain for greater than or equal to 1 month after onset of symptoms. So within 4 weeks of injury, remain for 4 weeks or greater after the onset of symptoms. In one retrospective study, the following conclusions were reached. Greater than 80% of post-concussion syndrome patients had at least one previous concussion. The average number of previous concussions was 3.4. Median duration of post-concussion syndrome was 6 months. 50% of patients were less than 18 years of age, and loss of consciousness does not increase the risk of post-concussion syndrome. All right. Next thing is how to prevent So I'll be stopping in management of after management of prevention of concussion. AAN, American Association of Neurologists guidelines conclude that protective headgear in rugby is highly probable to decrease incidence of concussion. However, American Medical Society for Sports Medicine hold that there is no clear evidence that soft or hard elements reduce the severity or incidence of concussion in football, lacrosse, hockey, soccer, and rugby. Biomechanical studies have shown helmets reduced impact forces on the brain, but has not transmitted into concussion prevention. There is insufficient data to determine whether one type of football helmet protects better than another in preventing concussions. No significant evidence that a mouthpiece protects against concussion. Okay. Management of concussion and post-concussion syndrome, return to play. No system of return to play guideline has been rigorously tested and proven to be scientifically sound. After sustaining a concussion, athletes should not return to play the same day. It's prohibited by some state laws. A symptomatic player should not return to competition if there is any uncertainty. When in doubt, seek them out. Evaluation should proceed in a stepwise fashion. A player needs to be completely asymptomatic, but at rest, with provocative exercise before full clearance is given. There is no standardized RTP protocol. Each player's progression should be individualized. Generally, the athlete's level of activity should be gradually increased over 24-hour increments from light aerobic activity to full contact practice. The athlete is evaluated after each progression. If concussive symptoms occur, then players is dropped back to the previous asymptomatic level. and then allowed another attempt at progression after a 24-hour rest period. 80 to 90% of concussions resolve within 7 to 10 days. This recovery time may be longer for children or adolescents. The CDC endorses a graded 5-step return to play for student athletes as shown below. The athletes should move to the next step only if they have no symptoms. If symptoms return, then one known or new ones develop, the medical attention should be sought. After clearance, then the student can return to the previous steps. So these are the step-by-step baseline. Athletes is back to regular. Okay, so to start regularly active without symptoms. Then we start with light aerobic activity only to increase heart rate for 5-10 minutes, no weightlifting. Moderate activity, increase heart rate with body or head movement. May include moderate intensity weight training, less time and intensity than their typical routine. Heavy, no contact activity may include running, high intensity stationary biking, regular weight training, no contact sports. 4, practice of full contact in controlled practice. And 5, competition. Those are the steps. Then management of post-concussive trauma, an extremely complicated topic, partly because of potential for litigation and the fact that symptoms are often vague and non-specific, and there may be no objective findings to corroborate subjective symptoms. Most symptoms from concussion resolve between 7 to 10 days and do not require treatment. The most common exception to this is post-traumatic headache, the most common subtype being acute post-traumatic migraine. Typical symptoms include headache, dizziness, insomnia, exercise intolerance, depression, irritability, anxiety, memory loss, difficulty concentrating, fatigue, light or noise, hypersensitivity. Patients with protracted symptoms may require more directed treatment. Psychological and neurophysiological improvement is often employed. Pharmacological treatment, there are no evidence-based studies of the utility of medications for post-concussive symptoms. Intractable headache occurs approximately 15% of concussions. Expert neurologic consultation is usually required for difficult to control headache. First-line drugs are over-the-counter medications. Triptans are usually employed for non-responders, and third-line drugs include ketorolac or ergot stars, dihydroergotamine 45. Steroids may be beneficial for some. Narcotics, barbitals, caffeine preparations, beta blockers, calcium channel blockers should be avoided in these patients. All right, so essentially that's the last thing. So essentially we've talked about post-concussions, concussion generally, the definition being 3 things. That first thing is that it is a complex pathophysiological process affecting the brain and resulting in alteration of brain function. That's 1. 2 is that it is due to non-penetrating biomechanical forces, and imaging, standard structural imaging does not find anything. So that's the essential definition. The next important thing to note is of course, the symptoms are known, then the tools for sideline assessment, like particularly SCAT-3, impact, those are the major ones. Then acute pathophysiology, of course, is important. So we know about the ionic influx and excitotoxicity that occurs. And then the energy crisis that can last for 7 to 10 days. So, and then this is directly correlated with the symptomatology. This table is actually important. Ionic influx can cause migraine, phobia. The energy crisis results in vulnerability to a second injury. And then external injury, impaired neurotransmitters, all cause impaired computation, slowed processing, and slowed reaction time. And then when there is cytoskeletal protein damage and cell death, and protein results in chronic atrophy and persistent impairment. And of course, we talked about post-concussion syndrome that occurs in 10 to 15% of patients with concussion. We talked about the symptoms, headache, irritability, delayed response, and all those other symptoms that the patients can have. And then we talk about how to return them to play and management of post-concussion syndrome, particularly post-concussion headache, depression, irritability, hypersensitivity, and all. So, all right, so essentially those are the things, the major things we've discussed today. We discussed exploratory borehole too, and then indirect optic nerve injury, post-traumatic hypopituitarism, fat embolism syndrome. Yeah, I think those are the major things we discussed. Yeah. Any questions, contributions at this point before we proceed to case? Questions, contributions? Okay. All right. Thank you, everyone.